And so what you're going to be hearing from now is really sort of the forefront of some of that effort, which is occurring actually in the military. The military, I think, is more attuned to looking at a population and saying, we need this population to not just not be sick, but be able to go the distance. Dr. Eric Schoomaker is a retired lieutenant general who served 32 years in active service in the U.S. Army as their Surgeon General, where he was responsible for the health and well-being of really everyone in the Army, and by doing so, also the nation's readiness. And then after Dr. Schoomaker, Ben Kligler will speak, and he is the National Director of the Integrative Health Coordinating Center of the Office of Patient-Centered Care and Transformation in the Veterans Administration. Before that, he was the Associate Professor of Family and Social Medicine at Albert Einstein College of Medicine, and was the research director in doing research on integrative medicine at the Continuum Center for Health and Healing. And he has also been the former chair. He was chair of the consortium before I was. So I'm introducing two really good friends. Eric Schoomaker will speak first.
It really is a privilege to be here, and I really appreciate the attention of such a distinguished group. Looking around here, I see a lot of friends and colleagues, and I noticed that even the folks I work with, a few of them came down here to make sure that I speak the truth. And I'll probably get a grade at the end of this, so really be enthusiastic about what I say, would you? Also, really a privilege to be and pleasure to be here sharing the podium with really leaders in this whole arena. And Margaret has been working very hard during her tenure in the consortium to try to get my community into the consortium. We haven't given up on that. We're still working. And I can't say enough good things about the Veterans Administration and the work that Ben Kligler has been doing, and Tracy Gaudet and Friedhelm Sandbrink and others who have really advanced this whole effort of integrative health, and especially that which applies to pain. So what I'm going to do here for the next few minutes is to take a little bit of a focus away from the whole broad area of health and well-being into one that is not that much narrower, frankly, when it comes to our communities, because there is no complaint that is more frequent or more a problem for patients than is pain. Pain is the number, in the military community, and I think the VA is the same, pain is the number one, number two, or number three complaint of every patient, regardless of why they've come. And if you think about that, and if you're a clinician as well, whether you're in sports medicine or in an orthopedics clinic or family medicine, wherever you are, you probably can mentally reconstruct the fact that the patients that you come to see in the main, if not in totality, are coming to you because they're in pain in some way, shape, or form, and are trying to work through that. And what I'm going to talk to you, and I think Ben's going to also touch on it, is what we in the federal medical community, especially the VA and the DoD, are doing to try to advance the use of integrated practices. Now, I was really pleased that the congressman helped me. Normally when I give this talk, I usually start off with a picture of a cholera epidemic victim being resuscitated somewhere where cholera is raging, with fluids, is being cared for this life-threatening diarrhea that results from it, and antibiotics at some point. But you don't treat cholera by just treating victims. You go back, as one of the fathers of epidemiology, John Snow, did in 1853 in London, an anesthesiologist himself who studied the epidemiology of where cholera victims were emerging from London and realized that they were clustering around the so-called Broad Street pump. And when he took the handle literally off the Broad Street pump, the epidemic stopped. Why? Because some mother had washed a diaper contaminated with cholera in a small depression in the street near the pump. It infected the water supply, and people then transmitted cholera. We are not in an epidemic of opioid addiction. We're in an epidemic of epidemics. And as one of the congressmen said, the epidemic begins with the epidemic of poorly managed pain in over 2/3 to 3/4 of the patients. So the diversion, overuse, misuse, ultimately opioid use disorder and addiction of the majority of our patients begins with pain management. And whether it's a 93-year-old woman who had a hip replacement, whose daughter I sat to on a plane, next to on a plane going to San Diego, to the meeting that was alluded to earlier that Bob was at and Len, where her mother, over the course of 6 weeks of recovering from her joint replacement, got addicted to OxyContin. Why? Because she was given a handful of OxyContin by her doc, and she was told, take this OxyContin every 6 hours for as long as you need it. And 6 weeks later, she's addicted. She's 93 years old, and this 65-year-old daughter has to go out and put her through cold turkey recovery. There is no program that she could afford to put her into, and there's no, except for a street program of street addicts and drug users in the San Diego area. She couldn't afford to put them in a high-cost drug rehabilitation program. So she said, the worst experience of my life was taking my 93-year-old mother through drug withdrawal from opioids over the course of the weeks that followed. And that's not an isolated event. That was a random stranger I sat to next to the plane. And I know Delta has figured out how to put me in the middle aisle, the middle seat, but they're not so smart to figure out how to put us next to people that are suffering from what we are studying. That event and that encounter is so common for us right now. So I'm going to talk about what we've done in the military, and quite frankly, I labeled this as the military and the VA because the VA is now leading the nation, in my view, in this effort, and needs to be commended for the work they're doing. Both Tracy Gaudet and Ben and many others. It's a really phenomenal thing. These images, I hope you stick, regardless of whether you remember what I say. But the images that I couldn't have put up 10 years ago of a soldier doing yoga, we couldn't even call it yoga. It was combat movement. But now that we know there's good evidence for these things, people are very accepting. And I'm privileged to work in a community, quite frankly, that our surveys every 2 years of use of these has shown that the military community is actually very receptive. Whether that's because, as the cynics say, that we frustrated them by not giving them treatments that work for them, or whether it's because many service members are stationed in foreign environments where they learn this. My own wife learned about integrative practices from a German acupuncturist on our second tour in Germany, or they marry a Korean, or they're assigned to Japan. But for whatever reason, they're far more receptive to the use of integrative practices than probably any other community. And now we're tracking that, and it's a remarkable experience for them. Real quickly, I'm doing this in my private capacity. I have to acknowledge the fact that my wife is a mindfulness meditation and yoga instructor. I don't know who speaks for the DoD in the U.S. and my university, but it certainly is not me. So there's no animation here, but all this is showing you is most of you are aware of the fact that we are experiencing unprecedented survival from battlefield wounds. If we tell a soldier, a Marine, an airman, a sailor, a Coast Guardsman, if you are injured in combat now and survive the initial wounding experience, the likelihood that you will survive treatment and recovery and rehabilitation is over 95%. That's an unprecedented, and we've done that through all of the efforts here, from better training and better equipped medics to soldiers themselves who know how to put a tourniquet on, as we've taught the people that treated then at the Boston Marathon bombing and others. Right back to evacuation, the Air Force has now put literally intensive care units in the air. We can put a soldier who's lost 4 limbs and half his blood volume on a plane within 10 hours after getting injured and flown back to the United States in an intensive care unit inside a C-17. That has never been achieved before. And frankly, the Air Force was able to do that for the first 50,000 wounds and injuries and illnesses of these war. 50,000 patients moved. They did not lose a single patient, despite the intensity of their wounds and the care. So it's just remarkable achievements. And then the rehabilitation. That soldier in the middle down there is actually a soldier we retained on active duty with 2 amputations. He became one of my non-commissioned officers that helped run our rehabilitative centers. I plucked him off the 2nd story of a climbing wall that we had at Walter Reed. He had adapted his prostheses to be able to climb the wall, something that I don't have the courage to do, quite frankly. And thank you for that reminder, Margaret, that we're all a little bit overweight. I am not going to hit the slider bar afterwards. So here's the pain challenge that we have. And I labeled this as that the military is the gateway into the Veterans Administration. Ben and I were just talking about this. We need to develop within the military the expectations and the processes and the orientation of our active duty that they can expect to see within the Veterans Administration, and so that we're one continuous, even though we're two executive branches with two different cabinet secretaries and two different budgets, we really need to build, continuous programs of health and well-being. And what you see here is that veterans and soldiers, and I'm a soldier, so I'll say soldiers instead of having to say each time soldiers, sailors, airmen, Marine, Coast Guardsmen, but I mean that. All service members experience more pain on average, and that appears to be even more so for women veterans. Remind you that between the VA and the DoD, we manage about 20 million patients. In fact, when we were out at the meeting that we talked about earlier, Bob, I think we counted the fact that the groups represented from Aetna to the military to the VA and others represented, 60 to 80 million Americans. We were talking about close to 1/5 to 1/6 of the whole population of the United States represented in these integrative efforts. And it's very important to realize that relative to the population at large, our patients experience far more pain. As you can see, it's musculoskeletal pain. And why is that? We all know about the combat wounds, and we can expect that someone who's lost a limb or had a severe, grievous injury to an extremity, and for every amputation, by the way, we have 7 times as many just grievously injured extremity wounds. The fact is that service in uniform is a contact sport. And what you see here, don't get caught up in the words. What was that, this? Okay. But look at the kind of the melody of this. And that is, relative to everything else across the first decade of the 21st century, kidney disease, cancer, cardiovascular disease, renal disease, which remain pretty flat. The 2 lines you see are behavioral health and musculoskeletal injuries presenting at outpatient clinics. And this is real data for across all of the services. So we say that if you're a 35-year-old light infantryman or Marine whose average basic load is 120 pounds and you're working at 8,000 feet and you're running 12 miles with a pack and a weapon, by the time you're 35, you've got a 65-year-old neck and a 65-year-old knee, and your back is shot. And that's what we're seeing here, is musculoskeletal injuries. So it's not wounds per se. The other thing we know is that pain, especially chronic pain, which is different than acute pain, and if we get a chance, we can talk about that. Once pain becomes chronified after 6 weeks to 3 months, it's no longer about tissue injury and nociceptive problems with nerves. It's a brain disease. And it's unique to every individual that revolves around your emotionality and revolves around your memory of pain, and with overlays of how your brain thinks of pain and the rational construct. And so these mind-body practices are very appropriate because they're probably interacting and interfering and redirecting parts of the brain in ways that we don't still understand. Very important is chronic pain very rarely in our population, and this comes from the VA, but it's overlapped with what we know in the active component, is very rarely a solo problem. It's usually in an interaction with a concussive brain injury, with depression, with post-traumatic stress disorder, with an alcohol drug problem, with other things. So it's a complex array, and we have to approach that as a biopsychosocial construct that, quite frankly, early pain centers like John Vaneka's Center out at the University of Washington also recognized and began to work on. And we've fallen off the curve of doing that. You all know this, that whereas in the 70s and 80s we were facing epidemics of these drugs and the use of these drugs that were restricted to cloistered areas, often of inner cities and selective ethnicities. Now we're facing an increasing rate of the use of prescription opioids that have led to an unprecedented death. This is the most serious health threat to this nation that we've suffered in 240 years. This will exceed the impact of the 1918-1919 Spanish flu epidemic. It killed 20 million people, 30 million people worldwide, but that happened in a year. It took people out. It killed half of all the people who died in World War I from non-combat wounds with Spanish flu, but it was over in a year and was gone. What we see now is an epidemic of epidemics with pain leading to opioid use, leading to hepatitis C epidemics where unsafe needle practice is used, to the loss of human potential, parts of the country that have less than 4% unemployment, but they can't employ anybody because they have a positive urine test, or they're a felon, or they're incarcerated. So now we've lost that. And now, for the last 2 years, we've seen declines in life expectancy that are directly attributable to this problem. And we aren't spared from this. We saw that. What we did is I stood up a task force called the Pain Management Task Force in around 2008, 2009. I said to them, look, based upon experiences of my wife and other patients of ours that I've seen, you need to open the aperture to integrative practices that are evidence-based. And to their credit, they came back, including Trip Buckenmeyer, Dr. Buckenmeyer, who helped lead this, and is himself an anesthesiologist and a proceduralist, says, you know what, I didn't realize this, but there's better evidence for the use of acupuncture, yoga, chiropractic, guided imagery, mindfulness meditation than there ever has been for chronic opioids. In fact, what is the evidence for the use of chronic opioids in chronic pain? None. None. There are no reputable scientific studies that show that chronic opioids in chronic pain work. In fact, there's lots of evidence that it causes huge damage, and even evidence that it may make pain worse in some patients. And yet the evidence for these practices are out there in abundance. Institute of Medicine, now the National Academy, followed a year later with their own larger study for the whole nation, pretty much overlapped. And what we saw at that time was the acupuncture, biofeedback, and yoga and meditation. Now we've expanded that to these music therapy actually has very good literature, mindfulness meditation, medical massage, Tai Chi, probably for cervical pain, the movement therapies. These all have good scientific literature and research behind them. This is to show you the coordination of the federal system in this regard. In the middle is a timeline from 2008, 2009 up to the present, and what you see there is the VA led, DoD followed. We put together consolidated products that are at the bottom here, Institute of Medicine study with the IOM report on pain in America. And then the NIH's Interagency Pain Research Coordinating Council was tasked after the IOM report by the Secretary of HHS to come up with a national pain strategy, which is under that star there. And that group put it together, published it. The National Center of Integrative Health then brought together the VA and the DoD. We now have a platform for doing research in integrative health that's been very successful. A couple of things real quickly, and I'm going to get the hook. If we can do one thing in this world that will transform it, it's adopting this way of measuring pain. We got into our problem in part because we were asking every patient, you've been to the hospital, the custodian asks you if you're in pain, the guard asks you if you're in pain, the clerk asks you if you're in pain, doc asks. We started chasing zero, as Jane Valentine says. This tool is that analog scale, but it adds functional interruption, and it asks, how is the pain interfering with your life? Sleep, mood, stress, activity. And when you ask patients that, it changes the whole way we go after this to one that's functionally based. We also have other tools. Last slide, and then I'll quit. The Samueli Institute helped us with this. These are the 4 quadrants that we feel are very, very important to attack in policy. In order to have an effective integrative program, you, number one, have to have an integrative care delivery system that's multimodal, that's multidisciplinary, that's team-based, and that's focused on patients. You need to get patients involved. You can't have patients passively looking to the system to inspire them to make things better. We need to engage pediatric populations and sports teams. You need operations within the health system that support it, and most important, you need a sustainable business model. The reason this is not being done, even though we know it works better, is there is no business model that supports this. So with that, I'm going to step down and say thank you very much. And Ben.